A brief overview of schizophrenia. Schizophrenia is a chronic and severe mental disorder that affects how a person thinks, feels, and behaves. People with schizophrenia may seem like they have lost touch with reality. Although schizophrenia is not as common as other mental disorders, the symptoms can be very disabling. The symptoms manifest in three ways: positive, negative, and cognitive. Positive symptoms are psychotic behaviors not seen in healthy people. They include hallucinations, delusions, thought disorders, and movement disorders. Negative symptoms are disruptions to normal emotions and behaviors. Symptoms include flat affect, or lack of emotional expression, reduced feeling or pleasure in everyday life, difficulty beginning and sustaining activities, and reduced speaking. Cognitive symptoms are changes in memory or other forms of thinking. Symptoms include poor executive functioning or the ability to understand information and use it to make decisions, trouble focusing or paying attention, and problems with working memory and the ability to use information immediately after learning it. For some patients, the cognitive symptoms of schizophrenia are subtle, but for others they are more severe and patients may notice changes in their memory or aspects of thinking. According to the DSM-5, in order for a person to be classified as schizophrenic, they must meet two or more of the following criteria in Section A and Section B and C respectively. The criteria for Section A is delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms such as those mentioned before. However, only one A symptom is required if the delusions are bizarre or hallucinations consist of a voice keeping up a running commentary on the person's behavior or thoughts, or two or more voices conversing with each other. According to criteria B, social or occupational dysfunction, the patient must for a significant portion of time since the onset of the disturbance have one or more major areas of functioning such as work or self-care markedly lower than the level achieved prior to the onset of the illness. Section C duration states that the signs of disturbance must persist for at least 6 months, and the 6-month period must include at least 1 month of the symptoms that meet criteria A. According to the International Diagnostic Criteria, in order for a person to be diagnosed with schizophrenia, they must have either at least one of the following syndromes, symptoms, or signs listed under 1, or at least 2 of the symptoms and signs listed under 2 would need to be present for most of the time during an episode of psychotic illness lasting for at least 1 month. So they must have either one of the following: thought echo, thought insertion, or withdrawal and thought broadcasting, delusions of control, influence, or passivity, clearly referred to body or limb movements or specific thoughts, actions, sensations, or delusion perception, hallucinatory voices giving running commentary on the person's behavior or discussing him and her between themselves, or other types of hallucinatory voices coming from part of the body, or persistent delusions of other kinds that are culturally inappropriate and plausible, such as religious or political identity, superhuman powers, and ability. Or, according to Section 2, at least 2 of the following: persistent hallucinations in any modality when accompanied by either fleeting or half-formed delusions without clear effective content, or by persisting overvalued ideas, or when occurring every day for 2 weeks or a month at an end, breaks of interpolations in the train of thought resulting in incoherence or irrelevant speech or neologisms, catatonic behavior such as excitement, posturing or waxy flexibility, negativism, mutualism, and stupor, negative symptoms such as marked apathy, ponticity of speech, and blunting or incongruity of emotional responses, or a significant or constant change in overall quality of some aspect of personal behavior manifests as a loss of interest, aimlessness, idleness, a self-absorbed attitude, or social withdrawal. There are genetic risk factors associated with schizophrenia. Throughout the world, schizophrenia occurs in approximately 1% of the world population, with similar genetic risk estimated in all cultures and people. However, the risk of schizophrenia is inherited, and the more closely related someone is to a person with schizophrenia, the greater the risk. The largest evidence for genetic risk in schizophrenia is a study of monozygotic twins. If one twin contracts schizophrenia, the other twin has a 50% chance of contracting the disease. The risk of schizophrenia decreases with the amount of genetics shared. Schizophrenia is a multi-gene disorder, meaning that there is not one gene responsible for it, and unfortunately cannot be identified by genetic testing at this time. There are also pre- and perinatal events associated with a risk for schizophrenia. Pre- and perinatal events like exposure to famine, radiation, a maternal illness, or stress, especially during second trimester, are significant risk factors for schizophrenia. Perinatal events like toxemia, or a spread of bacteria through blood, and hypoxia, oxygen deficiency at birth, are also risk factors. However, these events are not as predicted as genetic factors. In addition, there are also risk factors during childhood and adolescence. The typical onset of schizophrenia is between 16 and 30 years of age. At this time, in adolescence, the brain undergoes a large change during puberty, which could trigger psychotic episodes in those genetically vulnerable. Certain environmental factors also increase risk, such as marijuana use, which is typical during adolescence. Additionally, a stressful rearing environment during early childhood can also bring on schizophrenia. There are many brain abnormalities associated with schizophrenia, such as enlarged cerebral ventricles. However, ventricle size is a non-specific indication of cerebral dysfunction and could just be an epiphenomenon of the illness. Similarly, the cell bodies are smaller than normal, especially in the hippocampus and prefrontal cortex. As an example, schizophrenics tend to perform poorly on working memory tests and show deficits in memory similar to people who have damage to the temporal and prefrontal cortex. This makes sense when considering the prefrontal cortex is responsible for working memory. The thalamus, which is responsible for processing sensory information, is also smaller than average. The picture in the corner depicts the brain of a normal person on the left and a schizophrenic on the right. On the right, you can clearly see the enlarged ventricle cavities that are not present in the healthy brain. Other abnormalities include the reduced neuronal activity in the prefrontal regions and left hemisphere, strong deficiencies in the left temporal and frontal cortexes, which are responsible for long-term memory and working memory. The onset of schizophrenia often begins in early adulthood because the prefrontal cortex is not fully developed and hasn't assumed any important functions up until this point. The identification of several abnormalities suggests that schizophrenia results from several abnormal systems in the brain, not the deficiency of just one system. One hypothesis of schizophrenia, the dopamine hypothesis, states that excessive activity at dopamine receptors in different areas is responsible for schizophrenia. While the concentration of dopamine in a schizophrenic's brain is the same as an average person, the turnover is elevated, meaning that the neurons release dopamine at a faster rate and synthesize more to replace dopamine not absorbed. Evidence for this theory comes from drugs such as amphetamine, methamphetamine, and cocaine, which prolong dopamine activity in the synapses and can induce substance-induced psychotic disorder, which with hallucinations and delusions similar to schizophrenia, or the positive symptoms. Another hypothesis is the glutamate hypothesis, which states that schizophrenia arises from deficient activity at glutamate synapses. Because dopamine inhibits glutamate release, and schizophrenics have a higher rate of production of dopamine, they therefore have a deficiency in glutamate. Schizophrenics also have fewer glutamate receptors, especially in the prefrontal cortex and hippocampus, and have a lower than normal release of glutamate. This hypothesis is supported by the effects of PCP, which inhibits glutamate receptors. In doing so, it produces both negative symptoms of schizophrenia, such as loss of emotion and memory, and positive, such as hallucination and thought disorder. This then begs the question, why not treat schizophrenia with glutamate replacement? However, if we remember that strokes kill cells through overstimulation of glutamate, this may not be the best or safest option. While schizophrenia is a lifelong disease that has no cure, there are there are drugs used to minimize the symptoms. The first generation of antipsychotic drugs. In the first generation of antipsychotic drugs, there were two main families, pentathiazine and biotyrosine. Both of these drugs acted by blocking dopamine receptors. However, an often side effect in both of these was tardive dyskinesia, which is classified as trembling or other involuntary movements. This led to a second generation of antipsychotic drugs, which alleviate the symptoms of schizophrenia without the movement issues. The most common drugs are clozapine, amisulpride, and risperidone. However, these two have their own serious side effects, such as immune system impairment.